Just want to say that I have no conflicts of interest, and I will be speaking about off-label drugs. Sorry. Postpartum psychosis is an orphan disease. It's very rare, 1 to 2 per 1,000 patients or women, and it's an affective psychosis, 23 times higher in the first 4 weeks. Most women with postpartum psychosis have a bipolar disorder, and it can usually recur 50 to 80%, often outside of the perinatal period. The isolated postpartum psychosis, affective psychosis, is limited just to the perinatal period, the postpartum period. And this time tends to be the most vulnerable time for women regarding mental illness. And this was a slide by Kendall, and this was 54,000 births over 12 years, and these were 2 years of psychiatric admissions. He linked psychiatric admissions and childbirth, and found that in the first 4 weeks, then 3 months, was the height of psychiatric admissions for women for postpartum psychosis. It appears that there are 3 triggers to postpartum psychosis. There is, of course, the altered endocrine set point, heightened immune responsiveness, and a deregulated circadian rhythms, which probably are the predictors of a postpartum psychosis. So if you think about during pregnancy, over 40 weeks, the hormones are going up hundreds of folds. And then within 24 hours and loss of the placenta, the hormones go down back to baseline. And the fact is that hormones affect the brain. This is a picture of 2 brain cells. Of course, we have millions of them. And if we think of this one as being serotonin as our model, let's say for depression and anxiety, as we know, there tends to be, our concern is that there is a decrease, and this is, of course, one of our models that are probably much more complicated than this, but this is serotonin here. And what happens is of interest. There are lots of hormone receptors in the brain, and so just to demonstrate in one way they react, estrogen will decrease MAO and COMT, which are the enzymes that break down the neurotransmitters. So you tend to have more neurotransmitter. Progesterone increases MAO and COMT. And in fact, progesterone tends to have depressogenic effects. So the hormone receptors in the brain are basically in the amygdala and the hypothalamus. And through a series with the HPO axis, and the hormones will actually interact up here with the amygdala and the neurotransmitter receptors. And for women who are particularly vulnerable to psychiatric illness in the postpartum period, they will be more likely to become ill. So hormones were the first trigger, and then this was a study done by Berging, in which she found in bipolar women who had postpartum psychosis, there was an increase in monocyte levels compared to those who did not have a postpartum psychosis. And then, of course, we are concerned about labor and delivery, sleep loss, which may initiate circadian disruption, and the emergence of mania or mixed states. So you have 3 variables there that certainly can precipitate the symptoms of a psychiatric illness. You know, because postpartum psychosis is relatively stable across the globe. We tend to see it as probably more of a quote-unquote biological illness than most of the other psychiatric illnesses. Now, it's not to say that environmental factors are not involved, but the fact is there is a very strong biological component, so that bipolar mothers who have no family history of postpartum psychosis will have a 30% chance of having a postpartum psychosis. And if a woman is bipolar and has a first-degree relative who has had postpartum psychosis, then she has a 74% chance of having postpartum psychosis. This was a study done by Ian Jones in Wales, which demonstrated that bipolar families with one member with postpartum psychosis had a significant linkage signal on gene 16p13 and a gene-wide suggestive linkage on chromosome 8. There are also similar variants in the 5-HTT transporter gene. So as we can see, the bipolar families, bipolar women in particular, are subject to postpartum psychosis. And it's so important because so many of our patients are bipolar and so many are women, that it's important to be aware of how we can prevent this disorder. So there are three different presentations of postpartum psychosis. The first is actually the bipolar postpartum psychosis, and this occurs usually outside of the perinatal period as well as the perinatal period. The recurrence is 50 to 80%. Now, some women will just have a postpartum psychosis, even though they have no history of bipolar disorder. It's limited just to the postpartum period, and it is recurs in about 20 to 50% of the women. And then there is a major depression with psychotic features, which at this point we're also considering bipolar, but not absolute. Now, the complication, first, it is so rare that it really has been difficult, very hard to collect data on these women, looking at, the phenotypes and, treatment and prevention. Basically, this is a list from probably 100 years of clinicians reporting what this symptom profile is. Because postpartum psychosis, John Hamilton was an older perinatal psychiatrist, and he called it a picture puzzle. And part of that is because it presents as a cyclical mood disorder, mania, agitation, irritability, depression. The psychosis can be kind of atypical, so that you can even have visual, auditory, paranoid, and bizarre delusions. Often the bizarre delusions are circumscribed around the infant, so that there might be a thought that the infant is a devil or has some powers that will harm other children in the family. And then there is a cognitive disorganization. These women tend to be very confused and have often amnesia and have, what we used to call an organic presentation. But basically, it's a delirium-like presentation with lots of confusion, and it waxes and wanes. So a woman can look good at one moment and be floridly psychotic in the next. Now, probably could not give this kind of talk if it wasn't for Vera Bergink and her group in the Netherlands. The group in the Netherlands has amassed the largest database of women with postpartum psychosis from their mother-baby units. And it's interesting because what they found was exactly what all of the clinicians were finding. 34% had a manic presentation, 41% had a depressed presentation, and 25% had an atypical presentation. This is not something you can really read, but as you can see, they had regular objective testing to determine if the women endorsed symptoms. And in fact, again, these are the ones in the prior slide who endorsed mood lability, psychosis, atypical symptoms, and the kind of confusion and other symptoms that we see across the line with postpartum psychosis. The comorbidities tend to be autoimmune or inflammation in origin. Postpartum thyroiditis occurs in up to 20% of women with postpartum psychosis. Preeclampsia, there seems to be an association. And very unusual, but CNS antibodies. So that is very important when you're evaluating these women to obtain, not all women, only if they have neurological symptoms, NMDR, DAR, serology for encephalitis. So, as I said, many of the delusions are circumscribed around the infant. And although it's a rare disease, it deserves our attention because the rate of infant mortality, infanticide, is tragic and notable, to say the least. And Heron found that when he was admitting women with postpartum psychosis, 35% had infanticidal ideation. Either they had some severe behavioral disturbance that was manifesting as infanticidal ideation, or they were handling the infant incorrectly, or they were actually attempting to act on their delusions. Maternal mortality also. Suicide is the leading cause of maternal death in the first year after childbirth. These women tend to use irreversible and aggressive means such as self-incineration, jumping, or gunshot. Probably the most important message is to say that postpartum psychosis is a psychiatric emergency. Most important is to separate the woman from her baby.
I have a question. Is there something in the hormonal axis that makes them have male types of suicide?
I'm sorry, that makes them have?
Male. Usually women take pills.
Yeah, I think it's that they're so aggressive, probably because many of them are psychotic. You know how like a lot of psychotic patients will also use very aggressive means, and I assume that, I'm just assuming that that's what it is. I don't know that that's ever been looked at, and probably because it is so rare, you know, the illness in and of itself. But the psychiatric emergency is important because of that waxing and waning. You know, they really can look floridly psychotic and then seem quite connected at another time. So it can be very confusing, especially if like you're in an emergency room and you need to evaluate whether this woman has to be hospitalized or not. So the treatment initially is hospitalization, evaluating suicidal or infanticidal ideation, and providing safety both for the mother and the baby. The initial evaluation should be, of course, a physical exam, mental status exam, and a metabolic workup with CBC, LFTs, B12, folate, and of course thyroid function. Urine cultures and urine drug screens should be done as well. You don't have to do MRIs or CTs unless it's clinically indicated. And again, only CNS autoantibodies if there are neurological symptoms that make you, that give you some indication that this could be more than a postpartum psychosis. So treatment, you know, when I was a resident at Payne Whitney in New York, I remember that the attendings would always talk about how they can't seem to get the women with postpartum psychosis better, that it was such a tough, tough illness to treat and didn't seem to remit over time. And I do believe the reason for that was because they were only giving them antipsychotics and not providing them with mood stabilizers, as you would with a bipolar patient. So for mood stabilization, they should get either lithium or an anti-epileptic. They should be on an antipsychotic agent. After a time, if they are not getting well with the initial recommendations, or if they're acutely suicidal, catatonic, then ECT would be the treatment of choice. Even though the women have some depression with psychotic features, they should not be medicated with antidepressants. Often after the episode, that can happen, that they will end up having a depression, and then you just have to very cautiously provide antidepressant medication, going very, very slow with low doses. So this is some of Vero Berging's data. And again, I wouldn't be able to present all this, but she did actually an observational study on treatment. I'm not sure I agree with all this. It's not particularly a guideline, but it was interesting. When the women came into the hospital, they gave them lorazepam for 3 days to see if some of them just getting sleep would be able to reverse the symptoms. And actually some of them did. I mean, we tend to give lithium and antipsychotic almost immediately. So all of them, if they had no response, they would get ECT. The maintenance treatment was for those on the antipsychotic monotherapy. They stayed that way. I'm sorry, I should say something. When they received the lorazepam, the second step was antipsychotic. And then they had yet another step, which would be to add lithium. So the maintenance treatment was an antipsychotic monotherapy until 9 months postpartum, or antipsychotic and lithium, in which they then discontinued the antipsychotic and maintained lithium until 9 months postpartum, enough to keep their blood levels at about 0.6 to 0.8. 98% had remission at 9 months. But what's interesting is the rate of sustained remission was higher with lithium monotherapy than with the antipsychotic monotherapy. And of course, we will find that with bipolar patients, right? They definitely need their mood stabilization. When they are discharged from the hospital, or even before, it's very important to evaluate their support systems. And most importantly, I think, is psychoeducation. Many women don't know and don't understand what happened. And then there's a husband who said, am I going to get my wife back? What is this all about? So I think there are a couple of things. I mean, obviously, when it's important to discuss the prognosis, which is good, it's very important to talk about infant and patient safety. This can often be difficult because families do not want to hear, of course, that their daughter or their wife could possibly kill their baby. It is, of course, important to tell them that it can and it will likely recur in the next postpartum period, but that it can be prevented by using a mood stabilizer and an antipsychotic. They should be in intensive outpatient care or a program where someone is watching them regularly. These are the only women we tell that they should not be breastfeeding. No night feedings. They really need to get sleep in order to regulate the diurnal rhythms and to become more stable. Infant care should be monitored. The baby should not really be left alone with the mother until the outpatient psychiatrist says that it's okay. Because as we know, a lot of people, they shouldn't be with a postpartum psychosis, but a lot of people are discharged while they're still psychotic. I mean, in general, the rule is never send a psychotic mother home if there's an infant there. There was a time that they would send them home from the emergency rooms, but that shouldn't be done at all. They should have psychotherapy, supportive, of course, for the mother, but again, it's very important, I think, to have the partner in to discuss what happened, what's going on, and how each of them felt about all this, and the disappointment that they felt. I would say particularly mom, because she's really being deprived of her ability to mother. And that lasts for a few months because these women don't get well enough to take care of their baby on their own for that period of time. I mentioned Postpartum Support International, and this would be for postpartum depression too. This is a wonderful organization for both professionals and lay people, and the website has lots of teaching, lots of education, support. We have conferences, and it can be so helpful for a woman who's gone through this, who can see that others have. And so they can connect with these women also on this website. And on Wednesdays, they have chats with dads. So it kind of covers all bases. I'm mentioning bipolar depression, postpartum depression in here for a couple of reasons. One, we're starting to think that postpartum depression can be a marker for postpartum psychosis. So for example, these women, 45 filicidal women, were admitted to a forensic psychiatric unit. 76% were diagnosed with major depression, 24 bipolar. On discharge, that was actually reversed. So 73 were re-diagnosed with bipolar disorder. There was also the Bridge study, which was a Danish study of their population. And it was a population in Denmark. And they found that women who had early postpartum depression would likely convert to a bipolar disorder years down the road. Postpartum depression, again, the prevalence is about 10 to 20%. We use the first year postpartum, despite what the DSM-4 says. And I think there are these unique symptoms that apply to the baby, such as lack of interest in the baby and inability to care. The mom always feels guilty because she thinks she's a bad mother. She can't take care of the baby. Will often have bizarre fears about the baby, like, what if I throw the baby out the window? And I'm going to talk about that in just a minute, because it's important to identify whether these women are women who are going to kill their babies, or are these OCD kind of symptoms. So there's two separate categories. They feel detached or numb, feel almost like this isn't my baby. One woman walked into my office and she said, isn't this an ugly baby? Isn't she an ugly baby? Of course she wasn't ugly, she was beautiful. But I think it really does speak to the fact of the cognitive changes that one has during depression, that her perception of her baby and the detachment was really emphasized during this illness. And of course, thoughts of suicide and infanticide. Just brief treatment, cognitive therapy, or interpersonal therapy, only if it's mild or moderate. It may feel encouraging to be able to keep this woman off medication, but if she's not getting better, that's very important. And I must tell you that this was a little selfish. I have a kind of handbook on interpersonal psychotherapy for perinatal depression, so I'm advertising that, I admit it. Okay, so first choice for medication in the postpartum period would be sertraline or paroxetine. They have few adverse effects on the infants to date. On the neonate, there is minimal or no drug or metabolite. There is, of course, no long-term studies on these babies. If you don't know about it, there's a very good site called LactMed. It is ToxNet, and it's advertised by the NMH, and it will give you all of the cases of neonates who've received medications during lactation, okay, while breastfeeding. And it will give you the amount that goes into the breast milk or into the infant serum, and it will also give you any adverse symptoms that have been seen in the neonates. So, and it's all medications. So it's actually a very good site, and it's free. I think it would be hard to speak about postpartum depression in these weeks without talking about Rexanalone. You probably know that this is a new medication for very serious postpartum depression. Rexanalone is really allopregnanolone, which is a neurosteroid and a progesterone metabolite. And it has positive allosteric modulator effects on gamma. And Rexanalone decreases anxiety and depression. Now, there are actually two studies, but I didn't want to take a lot of time with this, so I'm just giving you the one study of 108 women who had postpartum depressions with Hamilton's of greater than 26. There were two arms of Rexanalone, one at 90 micrograms per kilogram, a 60 microgram per kilogram, and placebo. Rexanalone has to be administered IV. So the women were hospitalized for 60 hours. There were some adverse effects, just one woman with suicidal ideation and an overdose, sedation, dizziness, and actually one woman had an altered state of consciousness. And I guess, I think she fainted. So those things would be of some concern. This here is the percentage of decrease in the Hamilton Rating Scale for depression. This was Rexanalone. This was 60, and I don't quite understand why. This was 90, okay, and this was the placebo group. So by about 48 hours, they did well, and by 60 hours, these were the results. Then when they looked at them after 30 days, the effect continued. I should tell you, though, this is one thing about the study that, well, there are several things about the study. 25% of the women were on antidepressants before they started, so that's a confounding variable, certainly. But still, look at how their moods totally improved so quickly. And it's $30,000 for the treatment, which is very expensive. So what I hope from this is that it will be a segue to new medications for postpartum depression that are using this mechanism, perhaps, and can be given orally and not be so expensive. And in my estimation, I think the only women who probably should get it would be women who are acutely suicidal or were suffering very, very, very badly with postpartum depression. So, postpartum depression / OCD. There are some women with postpartum depression who get obsessional thoughts in infants and images about harming their baby. These thoughts are ego alien, okay? These are not women who want to harm their baby. They are distressed and they are anxious. And they even worry, oh my God, could I kill my baby? You know, staying out of their apartments till their husbands come home so that they go into the house. What if I put the baby in the microwave? What if I throw the baby out of the window? So of course you have to find out, are these psychotic symptoms of infanticide? The difference is, you know, I think many of us can recognize a psychotic patient, but not always. But the infanticidal thoughts are egosyntonic, and they're not suffering from the thoughts. For the other women, they get these thoughts over and over and over again, all day long. And then sometimes have images, like a knife coming down on the baby, something like that. So if there is any question, it is always worth having a consultation to determine what these symptoms are about. But I know there are a couple of women in the Rexanalone treatment who were absolutely amazed. You know, they suffered so much with the OCD, and then the OCD resolved after they had treatment. Treatments for OCD: sertraline, fluoxetine, benzos. I think my computer self-corrected quetiapine, because I think that's spelled incorrectly. But benzo or quetiapine for anxiety. And I mean, if it was really, really bad, clomipramine, but that's not usually what happens. These women usually get better pretty quickly and do very well. I'm just going to make a plug for quetiapine. I don't know if you all saw it, but in the American Journal, where discussing with the patient the risks and benefits of medication, and if you go over a couple of the studies, you always have to say, but there's lots of confounders. We don't know who drank. We don't know who used, alcohol. Lee Cohen from Mass General did the most wonderful study. I hope that this will be emulated now on all of the medication studies during pregnancy. And what he did was he gave them quetiapine. It was a usual placebo-controlled trial. But it was prospective. He had data on every woman about comorbid illnesses, other medications that they were taking, whether they were on any over-the-counter or any other medications. So it was all right there. And I'm just throwing that out because it can be so difficult when you're trying to provide informed consent to a woman for medications during pregnancy. So what about prevention? Years ago, women would never have another baby after having a postpartum psychosis. But let's say they have an isolated postpartum psychosis. We don't know if they're bipolar. They haven't had episodes before. Basically, if it would be important, recurrence would be just limited to postpartum. It would be important either to give prophylaxis prior to delivery or at the time of delivery. With a postpartum psychosis, I would prefer to give it before delivery because it can happen so rapidly. But that would be my recommendation, but some women would not be very happy with that and would rather not have any kind of exposure to the neonate. Recurrence of bipolar, the expression of bipolar postpartum psychosis, they usually recur outside of the perinatal period, so many will be taking prophylaxis during pregnancy, which would, of course, cover them into the postpartum period. Women who have major depression with psychotic features, more and more it is being considered the possibility of a bipolar disorder. So I don't know that I have any recommendations for these women. You could medicate when they deliver. You could watch and wait. But I think if somebody's been psychotic before, specifically with an infant, you want to catch the illness before it occurs. I say lithium lots because the lithium prevention studies have been around for such a long time. But I also think that if a woman has responded to another mood stabilizer, then it makes sense to give her that mood stabilizer as well. For the isolated postpartum psychosis, you either begin in the third trimester, begin lithium or the effective mood stabilizer, and begin the antipsychotic that was used in the previous episode. They should have an optimum sleep regimen. Night families, if possible, should be night feedings by a family member or a baby nurse. And there shouldn't be any breastfeeding for these women. So probably the most tragic circumstances for postpartum psychosis, and that's when you hear of it, although instead of the diagnosis, it's usually called like monster syndrome, infanticide in mothers with mental illness. The risk of being a homicide victim is the highest in the first year of life, and it accounts for about 1/3 of all filicides. 98% of the perpetrators are the biological parents, with mothers and fathers being equal. The United States has the highest rate of child homicides at 8 per 100,000 infants. England and Wales is 4.5 and Canada 3. This is important when I discuss with you what has happened in other countries in terms of incarceration versus hospitalization. So the history is such that infants were often used as sacrifice, or if they were malformed, they were just left by the roadside. Later in 1244, the church elevated it from a venial sin to a mortal sin, and then laws became more strict. In the 17th and 18th century, England, the United States, and Canada created laws that would punish women severely for infanticide. And yet, believe it or not, in 1647, Russia was the first country to provide more humane treatment, suggesting treatment instead of incarceration and punishment. By 1888, more than 20 European countries had some infanticide legislation, and that includes Canada, Australia, and the United Kingdom. In the United States, if I'm using the UK as our example of infanticide law, in the United States, we have really contrasting views with the UK and the other European countries. This is the Infanticide Act in England. In the Infanticide Act, it's not as if the women just walk away. They get a reduced penalty from murder to manslaughter because of the mental vulnerability due to the effects of childbirth before 1 year of life, because the balance of her mind was disturbed by not having fully recovered from birth. The offense, which would have amounted to murder, is deemed to be infanticide and is dealt with and punished as if it were manslaughter. So these women will get treatment instead of incarceration. Of course, it's not just every woman who commits infanticide. They obviously have to have mental illness. But that's very different from us, in which we have no laws governing infanticide. Women will get life in prison, the death sentence, sometimes probation, but it all depends on what court you're in, you know, who the judge is, if you have a good enough attorney. And we don't have the best mental health treatment in our prisons. So many of these women will come out with the same psychopathology that they entered with. Just briefly, in terms of looking at these women, their illnesses, the tragedy, and what can happen under the law, we have something called McNaughton. And basically what it says is, it has to know, did the defendant know right from wrong at the time of the crime? Or fail to appreciate, but many of them just use the cognitive focus. That's always confused me, even though I do tend to testify for these women. I mean, what do you say? Do you say, while you were killing your children, were you able to decide whether this was right and wrong? And what does right and wrong mean? I don't know if many of you remember Andrea Yates, who drowned her 5 children in the bathtub of her Houston, Texas home. Now, Andrea was profoundly psychotic, and Satan was in her presence, and his message was, you drown your children or they're going to hell immediately. What did she do as a psychotic but good mother? But she drowned her children. When it came to her trial, and the initial trial, the prosecution psychiatrist said, oh no, it was the defense psychiatrist, which was a problem. Legally, she knew it was wrong. Like, somebody told her at 7 years old, you're not supposed to do this because it's wrong. Morally, it was right. And that kind of makes no sense, right? Because how do you ask this question of someone who cannot even reason at the time? The other issue is we know more and more now that there is cognitive impairment during psychotic episodes. But this is exactly what we use in most of our states. She had, just to look at her childbearing history, she had 5 children, 6 pregnancies, 1 was a miscarriage, and she was lactating for 7 years. Now, McNaughton is a 160-year-old case. Can we really use our 21st century neuroscience along with a 160-year-old law? And in fact, the way this law came about was Queen Victoria asked a bunch of judges to go into another room during a trial and decide a way to determine whether someone has mental illness or not when they, perform their act, their murder or whatever. So it's not really scientifically, it does not have, of course, scientific grounds. And just to put this in perspective, in 1884, this is from the American Journal of Psychiatry, 1854, we were bloodletting, and today we use medications. So just so that you know the comparison of what we were doing in psychiatry in 1854 when this McNaughton came into play. So McNaughton is in 25 states. The model penal code, which essentially says the person did not have the capacity to appreciate, which is very different. The Durham standard in New Hampshire just says whether the act resulted from mental illness. And in 4 states, we have no insanity defense: Kansas, Montana, Idaho, Utah, and they also tend to be death penalty states. Now, this is something incredulous. The deific decree doctrine. Andrea Yates was an excellent mom. In 2002, she drowned her children in Tyler, Texas. She had the same defense psychiatrist and prosecution psychiatrist, and Satan told her what to do. Okay. Now, Diana Laney had all of the same issues. Excellent mom, Tyler, Texas, the same psychiatrist for the prosecution and defense. She stoned her children to death, but God told her to do it. So this deific degree, if you fail McNaughton, but if God told you what to do, okay, then you are found insane, because everybody knows that you're not supposed to listen to God. And it doesn't really, obviously, make any sense. So Diana Laney went to a psychiatric hospital, while Andrea Yates, who got her directions from Satan, went to prison. So the question is, what is our responsibility in the criminal justice system? Can we distinguish the insane from the criminal by whether the biochemicals in the brain are speaking to them through God or Satan? If impaired cognition is associated with psychosis, is it appropriate to use a law based on cognition? How do we apply this 21st century model of psychiatry to the 1843 case of McNaughton? Now, the other thing is the problem with the DSM, which, as you know, there are no postpartum diagnoses in. So while I was testifying, the prosecutor said to me, Dr. Spinelli, isn't it correct that postpartum psychosis is not a clinical diagnosis? To which I responded that the DSM does not necessarily provide scientific foundation, and that this comes about from peer-reviewed literature. But here's the issue with the DSM. In DSM-2, 1968, there was diagnosis of psychosis with childbirth, so there was a formal diagnosis. In the DSM-3 and 3R, it was stricken, the word postpartum, from the official nomenclature of the DSM for 14 years. This gave a generation of American psychiatrists who disregarded the existence of perinatal mental illness. Most would say it's just the same. DSM-4 and DSM-5 provided a specifier. So the specifier is, of course, just add the postpartum label onto psychosis. Whereas you saw, the psychosis is quite different. And if you just add it on to a psychotic episode, you're going to add antipsychotics. So they continue to deny a formal diagnostic criteria, which really flies in the face of biology. The incorrect diagnosis gives them incorrect treatment. It weakens its diagnostic credibility in the criminal court and discredits testimony. There is now a way of providing additions to the DSM-5. There's a site where you can add or suggest that you'd like a diagnosis to be entered. And I'm actually writing that proposal now. I don't know if it's going to be accepted or not, but I'm making the effort. Now, what about laws for infanticide? We're making some headway. In Illinois, there is a law that now recognizes postpartum illnesses as a mitigating factor in the sentencing for crimes. Postpartum Support International has a legal task force compiling a list of interested attorneys, providing legal education to interested psychiatrists, and providing a toolkit for attorneys as first responders. There should be a postpartum task force for DSM. There is not. Right now, there is a postpartum law that is pending in Massachusetts, and we're now getting a group together to do the same thing in New York. So instead of these mothers being treated like monsters, it's important to understand what they go through. Not just what they go through, but what they go through for the rest of their lives, having killed their children. So I hope this was helpful, and forgive me for adding a couple of things like the laws and such, but I can't talk about postpartum psychosis without talking about some of these problems for these women. So thank you.